Did we want to wait a little bit more, or do you think we're okay to begin?
I think we're good to begin.
Okay, sounds good.
Thank you.
So good evening, everyone, and thank you for joining us today for this PHSA Black History Month event, the final one. So today we'll be discussing this tremendously important issue, and we'll be able to gain some insights into why Black mental health must be transformed. So my name's Tionné, and I'm joined by Theresa, Meron, and Bemnet, and we'll be moderating this great discussion with our past professor and also our guest speaker today, Dr. Khenti. So before we begin, we'd also like to do a land acknowledgement. So we live and work on land that is part of the Dish with One Spoon Treaty from the original inhabitants of this land, the Anishinaabe, the Mississaugas of the Credit, and the Haudenosaunee. As uninvited guests, we are grateful to inhabit this land and hope to maintain the spirit of the Dish with One Spoon Treaty, to work collaboratively with the original inhabitants to protect it. As public health professional, I am also keenly aware of the specific transgressions that my professional community has historically and unfortunately continues to make against Indigenous peoples. Canadian public health policy and practice nearly exclusively reflect dominant colonial paradigms that reinforce the systemic marginalization of First Nations, Métis, and Inuit peoples living in now what is known as Canada. So I strive to do better in my work, and I vow to work collaboratively with Indigenous communities in research that involves their community, and where possible to prominently include this historically ignored population in my own research pursuits. And with that, I also encourage each of you to reflect on the land that you find yourselves on today. So before we begin, I'm going to hand it off to Bemnet, who's kind of just going to orient us into this discussion and where we'll kind of be heading today.
Thank you, Tionné. So by the end of this discussion, we're hoping that as learners, we will be able to define Black mental health or have an idea of what it is and identify how it's unique and differs from others, other mental health as well as other populations, as well as why Black mental health is important and what Black mental health looks like in the context of COVID-19 and this pandemic. We'd also love for this event to be engaging, so please feel free to speak up if you have any questions or comments. You can share as much as you'd like or as little, and if you prefer to share your opinions in writing, you can type in the chat as well instead of speaking. We will have a Q&A portion later on in the night, so please write down your questions in the chat and we'll hopefully answer them by the end of tonight. I will now pass it on to Meron, who will introduce Dr. Khenti.
Thank you, Bemnet. Dr. Khenti is building a global community of practice regarding effective public health and educational strategies to reduce and eliminate anti-Black racism. He lectures to diverse audiences, especially interprofessional teams, on strategies to reduce mental health and addiction stigmatization and promote Black mental health and well-being. Dr. Khenti also facilitates instructional sessions for learning and teaching about pre-colonial Black Africa, the enslavement of Africans in the Western Hemisphere, and African Canadian history. Formerly the Assistant Deputy Minister for Ontario's Anti-Racism Directorate, as well as Director of Transformative Global Health at the Centre for Addiction and Mental Health, and Assistant Professor with the Dalla School of Public Health, University of Toronto. Dr. Khenti has a specialist degree in economics, an MA in political science from the University of Toronto, and a PhD in health policy and equity from York University. Dr. Khenti has led a wide variety of international initiatives to strengthen mental health and addiction in primary care and to reduce stigma in healthcare. Dr. Khenti previously led CAMH's development of a specialized drug treatment and prevention program for Black youth in Toronto, the substance abuse program for African and Caribbean youth, and more recently, chronicled the effects of the social determinants of racialized gun violence in Toronto from 2004 to 2014. And Dr. Khenti is a special advisor to the City of Toronto's targeted COVID-19 Equity Action Plan and the chair of the Black Scientist Task Force on Vaccine Equity. Now I will pass it over to Theresa.
Thank you, Meron. We'd like to start by sharing a powerful video that was recently uploaded to the City of Toronto's YouTube page. And this video narrated by Dr. Khenti showcases a personal message about COVID-19 vaccination with Toronto's Black community.
During the days of slavery, people practiced their surgical techniques on black bodies without anesthesia or consent. Many cases like that sort of engender and sustain deep ambivalence to medical people who come to the community and say, this is in your best interest. And people say, really? Do you have my best interest at heart? We understand stigma on multiple levels because we are the recipients of racial stigma, mental health stigma, policing stigma, socioeconomic stigma, intellectual stigma, moral stigma. We don't need vaccine stigma on top of that. We have communities that are like islands unto themselves, socially disconnected from some of the more vibrant centers of Toronto. These communities were socially isolated prior to COVID, and during COVID, the isolation has been amplified. Ongoing experiences of systemic racism is evident in the chronic conditions that attract COVID, like hypertension, asthma, high blood pressure, obesity. These are conditions that are consequences of poor social determinants of health coupled with systemic racism. So that if you get COVID, you are more likely to have severe disease, more likely to be hospitalized, more likely to die. Sometimes you get the test first and the lesson afterwards. When you go to school, you get the lesson first and the test afterwards. But in the pandemic, we're getting the test first and the lesson afterwards. The test is this: will we be compassionate? Will we be respectful? Will we give people the space they need to make their vaccine decision rather than impose our vaccine decision upon them by saying that until they get vaccinated, I'm not talking to you. Until you get vaccinated, I'm not socializing with you. Until you get vaccinated, you are persona non grata in the family, in the community, in my space. Don't do that. Don't do that. Because of love. That's what love actually means. That's what unconditional love actually means. When people do things you don't agree with, you still love them.
So to me, community is teamwork, accountability, and togetherness.
Always staying in the house became very stressful for them. It's been difficult for me as well. So my home has become my workplace, my childcare center, and for some time it was a school.
You're kind of isolated for a bit where you just didn't really see anyone or didn't talk to anyone.
Friendship-wise, I think it really showed who your real friends are, and see you can spend time without them and still be close.
We don't want to add on top of those problems disconnected family life, disconnected love life, disconnection from the people we need, disconnected to the people we love. And that's why I say now is the time to take the vaccine in this current moment so that we can emerge from this pandemic experience stronger and more vibrant than we went in.
Such a powerful video. I will now be handing things over to our guest speaker, Dr. Khenti.
Thank you for that video and for showing it, Theresa. The video is so appropriate because I think that vaccination stigma, as has arisen in the wider society, evidence in the protests, the mass protests that we've had, not just in Ottawa and Toronto, but right across the country, would add to Black mental health vulnerabilities. It would fracture family life that's already strained by the Black experience of having to take on precarious jobs, 2 and 3 jobs, challenging during a pandemic, especially given the job losses and the diminished income. Black people have been disproportionately hit. From a socioeconomic point of view, they've lost more income had more job losses than their white peers. And the numbers are showing that already in terms of something like 39% have lost hours versus 12%. And the COVID disparities have hit Black communities and other racialized communities hard, not just illness, but death. More Black families have experienced the loss of loved ones than non-Black families. And that loss translates into unresolved grief, because during COVID, pandemic restrictions, public health restrictions have only allowed 10 people to participate in a Zoom funeral. And that Zoom funeral and the circumstances surrounding Zoom COVID deaths and what happened during the past 3 years, 2 to 3 years, is very, very almost un-African, because in the Caribbean and in Africa is actually more. We have something in the Eastern Caribbean called 9 nights. And 9 nights, some people have 5 nights, some people have 3 nights. And it's a time for mourning, celebrating, and healing. And the funny thing is, it's never been constructed as that, but that's the purpose that it serves. So during the 9 nights, the person who has lost their loved one doesn't do anything. The whole village, the whole street keeps coming to his or her house, cooking, cleaning, taking care of business. And all that person does is old talk. We seem to that old talk. That's not O-L-D, O-L-E, old talk. That means you're laughing, you're chatting, you're making jokes, and you're talking about the person who passed away. You're saying good things about them, bad things about them. And by the 9th day, you're just fed up talking about them, you want to move on. And we didn't have that. And that poses huge mental health risk because it's unresolved grief and grieving. And if you carry that, it could turn into hopelessness. It could turn into inability to let go, inability to move on. And that's on top of huge prevalence in this depression, huge prevalence in anxiety, more risk of psychosis, more risk of substance abuse, more risk of opioid overdose. And that's another arena that we don't even get into because of stigma towards people who are opioid users. Many Black people think of the opioid epidemic as a white or larger epidemic, not pertaining to them. But reality in the US, where they collect race-based data on everything, shows that even the opioid epidemic has had huge impacts on Black communities during the time of COVID. So it's mental health in the sense of depression, mental health in the sense of anxieties, post-traumatic stress disorder, traumas, and also even psychosis. So I hope that in talking about these things and making a video like that, to sensitize people to some of our cultural resiliencies, that we could actually think about how we cope. Not just cope, but think about how you cope so that you cope better. Because when you think about it, you're deliberate about it, you include it. Like I tell people, you know what? 30 minutes a day, you're gonna be laughing 30 minutes a day. If you can't laugh 30 minutes a day, something is wrong. So eat your greens, eat your vegetables, get your sleep, take your vitamins, but make sure you're laughing 30 minutes a day. Prescription. That's some of the best medicine you get for free, because that laughter boosts your immune system, strengthens your antibodies. You know all about antibodies now. You didn't 5 years ago, but everybody knows about antibodies now, immune system, T cells. Laughter actually helps you cope with COVID, not just stress and the distress, reducing your stress hormones, but actually alleviating and mitigating risk associated with COVID. So that's my way of introduction. And I'm so glad to be here tonight. Hope I can answer your questions and engage in thoughtful discussion and also learn, because I always learn from the questions people ask me, especially if I'm not able to answer those questions. All right.
Well, thank you so much. I think even just that introduction has already got people thinking. It got me thinking for sure. But before we move into those concrete questions that were already asked by some of our participants, I guess just to help orient the discussion, Dr. Khenti, in your opinion, how would you define Black mental health, what is it? How does it differ from broader discussions of mental health? Like, why is this discussion important, I guess, is the question I'm trying to convey.
Yeah. So the only reason we have Black mental health is because we have anti-Black racism. Without anti-Black racism, the mental health conditions that Black people have, or people of African descent have, would be no different than other people. You know, you have some higher prevalence in one area, lower prevalence in another area, but it averages out. In the Caribbean, the rates of schizophrenia are the same as in the UK and Canada for the population. But when people from the Caribbean move to the UK and move to Canada and move to the US, all of a sudden, their schizophrenia rates jump up. The depression rates jump up. The anxieties jump up. Now we have depression and psychosis and all that stuff in the Caribbean too, but it's not the same, and it doesn't express itself in the same way. And we have parity, interestingly enough, with the populations in what used to be the colonial countries, which is surprising sometimes given the experience what colonization involves, but there it is. So you come here and all of a sudden, you're starting to get sick from things that you didn't get sick from before. And in fact, again, because we don't collect race-based data systematically, we don't really know the differences. But in the United States, there's the significant different prevalence in Caribbean Blacks, African Blacks, or African Americans on all of the mental health condition, but it starts to disappear after the first generation. But it still holds by the second generation, but starts to disappear. So for instance, African American women have a prevalence of about 6% for cocaine, when for Caribbean women it's about 2%, illicit drugs, more generally, but cocaine as well. And that's because that cultural difference serves as a protective factor, just like the healthy immigrant effect, so that even though you're Black, but you're not fully exposed to that anti-Black racism, like the African American who has been there and who just sucks it in because they're born with it intergenerationally. So I think of it as a risk imposed by the Black experience that has been socially constructed in post-slavery societies, so that people who come here as Somali or Ethiopian or Jamaican or Guyanese or Trinidadian find that if they get a mental health problem, they're not treated the same. Not because they're Ethiopian or because they're Trinidadian or Jamaican, but because they're perceived as Black and defined as Black. And this experience engenders mental health risk that expresses itself as Black mental health risk. And it's not because we have a biological risk, but because of the socioeconomic conditions and the oppressive conditions that have been created for us to keep us in our place.
I think that's a really interesting point that you made. Why we're having this discussion surrounding Black mental health is because of that keyword racism. And I think that kind of leads a bit into the next question, which is, have researchers found a single most influential factor that impacts Black mental health? So maybe that is racism, maybe it's something else, but I'm just curious to know, you could answer this more broadly or specifically within the context of COVID-19, but what is that factor that's really affecting Black mental health?
So Black mental health is negatively impacted by the social determinants of health in the same way as it does with other groups, Latin American, South Asian, Eastern European. If you're Eastern European, living in a poor neighborhood, earning less money, having less education, you're gonna have poorer health. So just like anybody with that same socioeconomic variables, we have the same risk. What anti-Black racism does is amplify and worsen the impact. It amplifies the risk and worsen the impact of those key determinants, such as employment, housing, education, so that equally qualified Black people or equally educated Black people or equally experienced Black people earn less than their counterparts with the same credentials, same experience, same expertise. And on top of that, earning less, have to deal with microaggressions on a daily basis, which undermines their humanity, causing to question their self-worth, self-esteem, self-identity, perception of self. And the experience of that multiplies and magnifies the pain of the mental health problems. Because, you know, what racism also does is expose you to stigmatizing risk from the society, as well as self-stigmatizing risk from your own community or from ways that you have coped with what the society does. Racism is an accelerant in a way that makes ordinary mental health challenges worse. So if you're a Black person with psychosis, for instance, it's been found that you are more likely to experience coercive measures. With first episode psychosis, a Black person, twice as likely, sometimes 3 times as likely to get, go and not just enter the system in coercion, but experience coercion whilst there. And so the mental health experience is worse for you, which worsens your prognosis and makes recovery even less likely, just because you're Black. Same situation, just because you're Black, everything is worse. And that's what it is. That's why it stands out as a fundamental determinant of Black mental health. Not because, so it works through the social determinants, but it actually works with the social determinants sort of in parallel, right? So, and then through the criminal justice system, through the kind of experiences one has, you know, in the mall, in the restaurants, which, you know, just social pressure, you know, stress, what they call the emotional tax of being a Black person, a person of African heritage. And you wonder, why I have to deal with this? I just came to buy a burger. Why are you giving me a hassle? Let me get my burger in peace, eat my burger in peace, come with me. No, you know, you gotta be giving me stress. And that's what it means.
So it sounds like racism is that factor that really just amplifies all those pre-existing social determinants. That's the sense that I'm getting.
Yeah, it amplifies it, but it's a fundamental determinant because when cures are found or situations improve for those conditions, it doesn't have the same positive impact for the racialized. That's why it's a fundamental. You almost think as though there's a evolution of the problem. So you end up still having higher rates of depression or higher rates of anxiety, even though there's better therapies. But the better therapies don't improve your conditions in the way that's expected from the improvements in the therapies.
And I know
Does that make sense?
Yeah, that makes a lot of sense. And I guess I'm wondering, I know there's a bit of a positive research in terms of Black mental health, Black health in general, but in your research or maybe things you've come across, have you happened to see if there's any particular subpopulation that's overrepresented in poor mental health outcomes, whether it's women, immigrants?
Yeah, so women have more depression issues than men. But that's because women internalize and men externalize as part of the gendering process, as what we think of as gendered, the proper gendered way to respond. So you have a bigger prevalence or higher prevalence with illegal drug use among males, but depression in women. And that's not just with Black people, but worldwide. You have the difference. Ask me that question again.
If there was a particular subpopulation that's overrepresented in poor mental health, I guess statistics or things like that.
Yeah, so here's the irony of the situation. Employed Black people have higher rates of depression than unemployed Black people. Why would that be? Well, the microaggressions you experience in the workplace is so stressful, it weathers you down and ages you prematurely and takes a toll that the person who isn't working, who isn't exposed to that, doesn't have. That doesn't mean they're not depressed because they're out of a job or unemployed. It means that you're having to deal with more stress in the job than they out of the job. And that's like some people who don't want to go back to working in the office. They've enjoyed working in the home. Those people who were lucky enough to be able to work from home. And that includes a lot of Black IT workers in the US who, when they're surveyed, said that they don't want to go back to the office because it's been safe at home. And some well-performing Black adolescents in high school have expressed the same sentiments. that they have flourished at home. Unfortunately, that's not the reality for most low socioeconomic Black students, but it tells you something. You know, I think the point needs to be made that in Canada, from a study from the University of Ottawa found by Sinat et al., a group, that about 67% of the prevalence for depressive symptoms is about 67% of Black among the study of 845 Black Canadians, which is huge, even by comparison with Blacks in Brazil and Blacks in the United States. And 25% of that is attributed solely or singularly to racism, experiences of racial discrimination. You know, when you factor out the social determinants, the huge disparity is driven by racism. And our women bear, and our women, our employed workers bear a heavier burden because of it, a heavier mental health burden, more stress. So racism is gendered. And let me just add one more point on that. And it's gendered in a different way, for instance, that you normally expect, because I actually think homicide victimization in Black communities in North America and South America, particularly Brazil, is an expression of a gendered male mental health problem induced by racism, anti-Black racism, deep anti-Black racism in society, which leads to this quick resort to violence and murderous violence as a problem-solving tool between young Black men. So that in Brazil, you know, it's like we are 50% in Toronto and Montreal. Brazil is the homicide victimization rate is a Black, not 90% Black in Brazil. Huge, and that's across almost every Brazilian city, whether the Black population is small or large, same thing, right?
Mm-hmm. No, like there's so many different determinants that are just impacting mental health in so many different ways. So I think it's a lot to think about, but I think it's very interesting and also kind of forces us to think critically about what we need to look at in order to actually address it.
Agreed.
But no, I think this portion has been so insightful, but I'm also going to hand it off to Bemnet for our next question.
Thank you, Tionné, and thank you, Dr. Khenti, for answering the first. The second question, moving forward with, now that we've looked at determinants and like factors that affect Black mental health, we wanted to move the conversation into barriers to accessing mental health services, specifically for Black communities. So beyond, like also understanding through anti-Black racism, but beyond that, what are other barriers that look like for Black communities, as well as like what that might look like within the context of COVID-19 and how that might have changed.
Thank you. And I might ask you to, tell me if I don't answer the question fully, I'll do my best. The biggest barrier is the lack of sufficient numbers of Black mental health therapists or resources to address mental health problems. And you know, StatsCan did a survey during COVID, I think it was 2019, late 2019, early 2020. And what they found was that we have this huge prevalence of mental health problems, but they also found that 60% of the respondents in their survey, cross-country survey, of Black people who said they had no mental health problems, 60% of the people who said they had no mental health problem said that if there were Black mental health professionals close to them, that they would go and see them. They would, which tells you that if you're saying you don't have problems and you would take the opportunity to go see a mental health professional, that means you're sending me a message that you really do have a problem, but you're not going to articulate a problem. But if the supply, you take the supply, right? So not having Black social workers, Black psychologists, and Black psychiatrists makes a difference for the help seeking of all Black communities. Actually, I can't think of anyone that breaks that pattern of help seeking, which is a very strong problem across all Black communities. Delayed help seeking. So that's a barrier. So the barrier is human resources, but associated with that barrier is something called delayed help seeking, because people not seeing themselves represented in the staff wouldn't seek help, or feel, less likely to seek help. As a result, by the time they absolutely can't avoid seeking help, their prognosis worsens, and their depression is worse, their schizophrenia is worse, their substance abuse is worse, and likely harder to solve, right? So that's one of the biggest barriers. Another big barrier is the lack of research into the problems that Black people have, especially the racial trauma and the links and association between racial trauma and our psychological or physiological responses, which often translate into us having stress hormones, like normal people having stress hormone. I said normal, people who aren't diagnosed as having an anxiety disorder, for instance, but have stress hormones equivalent to the non-Blacks with an anxiety disorder. You understand? And that's because of living Black, driving while Black, walking while Black, working while Black, talking, has so many stress engendering aspects to it. And we need to really research it on multiple levels so that we can understand it, but also so that we can diagnose, have proper diagnostic tools and proper treatment protocols for how it's dealt with, as opposed to everybody, it's a free-for-all, everybody has their own approach and nobody knows what really works or doesn't work, because we don't know. And on top of this racial trauma in contemporary society, we also have on top of that historical trauma, which sits at it's like the foundation. And I think it's very important to understand that as well from a historical point of view, but also because it produces other kinds of problems. And it's not traditional or conventional mental health problems, but it's problems. Beauty, the dissatisfaction with the African phenotype. Why so many African people have a problem with how they look. They look in the mirror and they don't like what they see. And that's not a new problem, that's an old problem. And where did it start? How did it get to such a level that, people, so in Africa, you have a skin lightening problem with the skin lighteners in West Africa and East Africa. But then people come here and still use skin lightener. I mean, and you see, so that's just one aspect to it. I mean, but, appearance, hair, I could go on and on, but we have anti-self disorders that aren't in any DSM form manual, so that we really don't understand, we really don't, and I could tell you and I'm just give you, so someone who comes from the Caribbean and has a strong African phenotype, very dark, looks very African, and someone would say, "You from Africa?" He said, "Me from Africa? No, don't call me, I mean no African, don't call me no." They get upset and say, "I'm not African, don't call me African." Crazy. What's the offense? What's the insult? What's the problem? But it's because of the conditioning of the culture, which makes people uncomfortable with the association to the extent that they reject it. And to me, that might be a conventional mental health problem, but it is a mental health problem, because you look in the mirror, you know what you're seeing, and what you're seeing is somebody who is indistinguishable from a Ghanaian or Nigerian. You can't even tell the difference, but you feel the difference, and on it goes.
I think that's an excellent point, and I'm glad that you raised it, because that does contribute, and I think the historical treatment of Black Canadians definitely plays a role. You also mentioned, I guess there's less Black mental health like workers, social workers, professionals, as well as a delayed help seeking within the Black community. Could you speak more to why there is like a delayed, you mentioned in the video earlier around stigma and how that might be one area around it, but could you just dive in a bit more there?
Yeah, so I'll dive in and add on to that. So on top, the stigma the perception of mental health problems as weakness or moral failures is so huge that people don't want to talk about it or say I have it, you know. And this is a particular case with Black women who experience depression or anxiety, but keep it to themselves. They show the tough, strong Black women. They're supposed to be feeling fear, you know, this, or having a phobia about going out, or just being so anxious about everything, you know. So we have this idea of strength. And then we also have the idea of causality, which isn't the traditional Western causality model of thinking, where we attribute illness to other sources than biological phenomena. And I laugh because, you know, it is I mean, I'm not to put it down, but hey, I've had people tell me, you know, I'm feeling the pressure and then somebody give me the eye, somebody give me an evil eye. And I feel I know who, and if I hold him his licks, but you know, you think this is a joke, but people have committed murder because they thought somebody gave them. A friend of mine, his cousin was murdered by a guy who lost his job and believed the main reason he lost his job was because this guy gave him the evil eye. And he came to the guy's house, knocked on the door, shot him dead. I mean, like, you know, so we have a system that is wacky in certain ways, but at the same time, it has deep roots in culture because people believe that when things happen to you, it's not just because it happens to you, it's because there must be something that you did, or there must be broken relationships. Something has to be out of whack in your family life, in your social life, in your community life, in your ancestral life. So depending upon your belief, like in Haiti, they'd say, yeah, you know, you haven't gone to the grave and paid your respects. That's why this is happening. Or they do some dream analysis. This is what your ancestors are dissatisfied because of this and this and that. So we have, again, an understudied area, because I don't assume just because it doesn't fit with the Western model that it's not relevant and deserving of equal weights in a mental health setting. And that's one of the reasons when I was working in Tanzania with traditional healers, what we did was we developed an app, a telephone app for the traditional healers in northern Tanzania where there's no psychiatric facilities, so that they would determine when they felt someone was experiencing schizophrenia or psychosis that was something beyond their means, you know. So they would be, you know, they'd be working with the person to use whatever they use traditional medicine. But if they felt that there wasn't a problem that traditional medicine could solve, they would be able to use this app and refer the person to the mental health facilities or mental health resources. And that's a way of respecting not just their culture, but reality, because there'll never be enough psychiatrists in a place like Tanzania or Haiti to treat even remotely poor people. 10 out of 100 poor people. So, you know, so you have to do that. And the other thing that I think is missing, the other barrier, is a lack of clear elaboration of what anti-racist cultural competencies mean, so that non-Blacks could treat Blacks effectively. Because there's some Black people who don't want to be treated as Blacks when they go into treatment. So they ask them, there's a Black program here. Do you want to go to that? Said, at least half say, no, all right. Look, I'll just take the conventional treatment. Okay, take the conventional treatment. But how do you make sure that the conventional treatment is up to speed on anti-racism so that the system doesn't repeat itself and there's additional problems from the treatment? Bearing in mind that no harm in the health arena, you shouldn't be adding harm. So if you can't solve a problem, don't add a problem. And so the third barrier is the lack of that distinct anti-racist competencies, which are cultural competencies as well as anti-racism culture. Knowing how to ask the right questions. What are the right questions? Have you experienced trauma? How did it happen? Tell me, because I don't want to be doing or saying anything that might add to your pain or your disconnection. That's why I just want to make sure that we can get to substance abuse or get to the gambling or get to the depression without me being a problem for you. You know, that's the third barrier.
No, I think that's a great point, because I think that often is left out of the discussion, like in seeking help, how that might contribute to your mental health as well. So thank you for raising all those excellent points. I don't want to take away from the discussion because we do have some other questions. So I'll pass it on to Meron. Thank you again, Dr. Khenti.
My pleasure.
Thank you, Bemnet. Now we'll move our discussion towards vaccine hesitancy and medical distrust and its impact on Black communities. So my first question I had is, how would you describe vaccine hesitancy, and why do you think there is hesitancy about COVID-19 vaccines within Black communities?
So Black communities have the same vaccine hesitancy that exists in all communities for the same reasons. They're worried about the speed with which the vaccines were produced. They think corners might have been cut. You know, remember Trump called it warp speed, Operation Warp Speed. Warp speed kind of tells you, oh my God, what the hell was going on warp speed? And they also worry about safety, the safety of the vaccine, not the fact that it's new, it doesn't have a long track record, and they wonder if that's a problem, right? And that's what the white community, Latin American, Asian communities, many other communities are worried about and have the same vaccine hesitancy issues. So with respect to that, you know, you sort of show them how the vaccines were manufactured, the research that went into the vaccines, 20 years of research on coronavirus, as well as other things, you know, because they were trying to develop vaccines for other health problems using the same mRNA technology. But then on top of that, what Black people have, but also Indigenous people have to also a significant extent, is historical mistrust. I believe that the system lacks empathy for their pain and is quite willing to conduct experimentation on Black bodies. That's what's different about Black people, because they have all these cases they can point to, like Tuskegee, like talcum powder, like this pharmaceutical company in Africa that tested a vaccine on children without getting consent. And the vaccine didn't even work either. So, you know, two big problems, which they were found guilty of in court and had to pay out, and it all resolved effectively, but the pain lingers on. And yeah, so there's that idea, and it's sort of reinforced by the reality of racism in healthcare settings. And if you experience racism in healthcare settings regularly, where you go into the healthcare system expecting quality care and getting none of it, not being taken seriously, not being listened to properly, and not being prescribed medication that make the pain go away, you start to wonder, do they really care? Why am I even bothering? And enough people have that experience, believe me, to sort of build us a critical mass of mistrust. It really is. And before I took this town halls, I didn't realize the extent of the mistrust. You know, I tell people if you have so much mistrust, there must be a reason. But at the same time, in a pandemic, in a crisis, in an epidemic, you have to be able to weigh the risk associated with your experiences with the risk of the current situation, the current vaccine. And the current vaccine has to be contextually analyzed. Context is everything. And critical race theory says it's all about understanding the context, both historical and cultural, in order for you to really glean or glimpse the truth. And the truth is that these vaccines were produced to save the lives of wealthy people, wealthy populations. They weren't produced to save the lives of Black people. Black people, just like other ethnic or racialized groups, are the beneficiaries of the geography within which they find themselves and the high-income jurisdictions within which they find themselves, because people at the lowest income levels of the world, the poorest countries of the world, whether it's in sub-Saharan Africa or Southeast Asia or wherever, are largely unvaccinated and left to their own devices during the pandemic. 80% of the people in Africa have not even received the first dose. We're talking about 4th dose and 5th dose. So I try to bring that kind of context so people can say, well, you know, and I'm telling you that as someone who has family in Africa and the Caribbean, who my uncle had to wait for his AstraZeneca vaccine, which was donated late, but thank God he got it. He was able to travel. He didn't want to take the Chinese vaccine because he wanted to be able to come to Canada. And that was before the Chinese vaccine was recognized by the World Health Organization and accepted as a vaccine that you can come to Canada with, right? But in Africa, I have relatives in Uganda and Sudan who have never seen a vaccine, yet to get a vaccine. And they're facing everything. They're facing the neglected diseases plus COVID. You know, they're facing malaria plus COVID. So, you know, that's the unjust, that's the gross inequity in our period. We are honorary whites. We are privileged. We're experiencing and enjoying privilege that we're not accustomed to. And that actually raises up the suspicion. I tell people, hey, I know my relatives say, if you can get a vaccine, take the vaccine. Don't worry about, you know, the equity issue in about you're not taking away a vaccine from me. I want you to be vaccinated. It doesn't make sense for you not to be vaccinated if you have access to a vaccine. So, you know, it's a difficult conversation to have, but you got to have it. And that's what the issues are. So it's global vaccine inequity is the biggest moral transgression of our time. And now we see more and more, the way Russia invaded Ukraine, that's another moral transgression of our time that people are saying is the worst moral transgression. But hey, I could argue that the Ethiopian bombing of the Tigrayan is the most moral aggression in our last year. You understand what I'm saying? But that doesn't register on the Richter scale of moral transgressions the way other moral transgressions do. And that's the problem. And you know, so what we have, overexposed, working in healthcare, 20% of our population, the Black Canadian population working in healthcare, nursing aides, PSWs, nurses, healthcare aides, supports working in a nutrition place or the dietary support staff or what have, or cleaning the hospitals or what have, 20%. That means we're overexposed to COVID. And that 20% doing 2 and 3 jobs. They're not just doing 1 job because the pay isn't that great. So they need 2 jobs, they need 3 jobs. And then they're doing 2 and 3 jobs and they still don't have no benefits, still don't have 10 sick days. So they're facing higher risk and they still don't want to get vaccinated, believe it or not. They're still afraid of that vaccine. I have a dad in a care situation, and he has dementia. And like about 4 in the last year, about 4 of the PSWs, the Black PSWs got COVID. And every time they get COVID, he's in lockdown too. You understand what I'm saying? Because he's exposed, even though he has now 4, they vaccinated him 4 times. They got 4 vaccines. Terrible situation going on because when you die in COVID, you die alone. You understand? And you know, I tell people, look, you don't want to die alone. You don't want to be in a hospital room by yourself, begging a nurse to hold your hand. When the person who should be holding your hand is the person who loves you and who's going to tell you they love you, just, you know, because that's what you need to hear from them. You understand what I'm saying? So that's what we do. Even talking about it and getting that close, it's so easy to get emotional, let me tell you, because it is a reality that many people are not exposed to and they don't take it seriously enough.
Thank you so much, Dr. Khenti. I really appreciate your comprehensive answer and really just not looking at vaccine hesitancy, but looking also at Black communities nationally and internationally around the world, and really focusing on vaccine equity and the importance of really making sure that everyone has access to this vaccine and improving the health for all. I guess my next question is, how does vaccine misinformation harm Black communities?
Oh, wow. Well, vaccine misinformation amplifies mistrust, erroneously so, and and reinforces the delayed help seeking, which we just talked about. so that people are less likely to seek help because they think the help will not be up to par, or the help isn't help at all. The help is a problem. And you have what they call digital blackface, where we have misinformation posing as black accurate information. It's actually misinformation and designed and tailored to amplify Black hesitation to get vaccinated. And and they talk about the fertility risk, that there's a plan, a conspiracy to diminish Black fertility. And you don't want to find out next year, so don't get the vaccine, because your 12-year-old or your 13-year-old is going to, once you're ready to have a child, you can't have a child, right? And that's very strong and very prevalent and spinning all the way across social media. Microchip is being installed to track your whereabouts, track your movements. You think you experience police surveillance? Well, wait, when you get a microchip and you be seeing a drone following you all over the place. I'm laughing, but I'm laughing because you gotta laugh. You understand? We leave the stress, because really, people believe that. They believe that, that microchip. So I tell people, the microchip can't fit into vaccine yet. Maybe in 50 years, they'll have a microchip that's water or liquid, but right now, they don't. So you can't vaccinate somebody with a microchip. You can't affect the fertility. In fact, they had a study of some women who were trying to get pregnant in New York State, and were using, what do they call, what is it? I forget the acronym. Not intravenous, anyway.
Vitro?
Yeah, in vitro. Thank you so much. And the unvaccinated and vaccinated has similar rates of pregnancy. And during the vaccine trials, you couldn't get into the trial if you were pregnant, but there are a lot of people who got pregnant in the trials. So you have to tell people that to address that. But yeah, the misinformation is huge, and the misinformation disincentivizes people who are at more risk. That's the problem. They are more risk, and now they're becoming less likely to go and get vaccinated when they have to go to work tomorrow, regardless. So they have to take the bus tomorrow to go to work in a congregate setting. So, and if they get sick, what's also important is they're more likely to have chronic conditions. And that's up the socioeconomic ladder, more likely. So you could make a lot of money and still have high blood pressure, heart disease, diabetes. Income, education, and money don't have the same protective effects. It has protective effects, but not to the same extent for Black people as for non-Black people in our society and in our culture. That's because you're still getting stress, anti-Black stress, as you go up the income ladder or go up the professional ladder, or even if you go up the housing ladder and you move into one of Forest Hills. You're in Forest Hills, but you're getting stopped by the police more than anybody else. In fact, you're getting stopped more than if you lived in Jane and Finch, because people stop you and ask you, what are you doing over here? And that's what the data shows from Akwasi, Owusu, Kent Bemper, the people in or Scott Watley, the people in these neighborhoods get more surveillance, thus experiencing more stress, even though they got their money to mitigate the stress. I think I answered the question and more.
You did. Thank you so much. Yeah, so provided great information into the spread of misinformation and how rampant that is, and how that plays a really large role in reducing the community's trust and confidence in the process. You also discussed mistrust of systems and mistrust of medicine based upon historical legacies of medical exploitation and persecution at the hands of healthcare systems, and as well as continued medical racism that has given the Black community reason to be skeptical and hesitancy. So my next question is—
So can I add just one thing before you go on?
Yes,
I don't like to, so the reason I want to add is because when you talk about this medical racism, amorphous, I don't like these amorphous things, so people don't know what you're talking about. But let me give you one example having to do with opioids. Coming from the US, but I think, Black people with opioid addiction are less likely when they see physicians to get medicated or even to get buprenorphine. And it had good benefits in the 90s because there's been 3 waves of opioid epidemics. The first wave was heroin, the second wave was prescription drugs, the third wave is prescription drugs, heroin, and fentanyl. So in the first wave, Black and whites equally affected. In the third wave, Black and whites equal. In fact, Black are now being more affected in the States from the current wave of fentanyl and all of these things. I think it's the same in Canada too, but we don't have racial statistics, so we don't know. But in the second wave, in the mid-wave, Black mortality didn't change or increase. Black mortality actually went down because Blacks, their pain wasn't taken seriously by physicians, so they weren't getting, the physicians think they're trying to pull the wool over their eyes or something, because, and they wouldn't give them those prescription codeine or opioids or whatever to mitigate their pain and to deal with pain and cope with pain. But they were actually doing them a favor. But it's one of those ironies of history that they didn't mean it to be, did it for the wrong reason. But just talk about medical racism, there it is. Not diagnosing you properly because they just have the blinkers on. And all they're seeing is Black. They're not seeing a Black person, they're not seeing the opioid addiction. They're not seeing the other things that drive you to the opioid addiction, the joblessness, the poor housing, the everyday life in misery. And in fact, many of them are war veterans, so they're not even seeing the war vet. You're not even a war vet in a place that treasures their war vets, so to speak. So there's a case of contemporary medical racism that's very real as we're talking about opioid addiction and opioid overdoses and stuff like that.
Absolutely. Thank you so much for that answer. I agree with you. We're in the era also of medical racism. It's not only a thing of the past, unfortunately. And in the context of institutional medical mistrust in the Black community, what are some ways we can really rebuild our trust? We know this is going to be a long process. It's going to be easy. It has to be meaningful.
So I say, don't worry about rebuilding trust, because I don't believe we had trust. It's just that the lack of trust never created so many disparities that it was obvious to all. And we never had race-based data like we do now in Toronto around COVID to have a sense of racial disparities in this health phenomena like we do. However, we do know that trust matters. Trust between patients and providers leads to better outcomes, better experience as reported by the patients, and recovery. And patient satisfaction is better when they report trust of the provider. So the question is, how do we improve the relationship, client-patient encounters, so that there are quality encounters? And the most important thing, I think, is accountability mechanisms, so that when things go wrong, transgressions occur, people are held accountable. And one of the biggest problems is lack of accountability. So people could say things and do things, and it's never dealt with seriously. And so we need platforms in healthcare to address racism. It needs to be clear, it needs to be transparent, it needs to be obvious. People have to be also, but at the same time, people should also be trained. Again, this is where anti-racism comes in, anti-racism. Policies need to be in place, expectations around empathy and communication and listening, and also very important, trauma-informed care. People talk about trauma-informed care without even knowing what trauma-informed. They think they know what trauma-informed care, please, because they know what trauma is and they know what care is. But what does trauma-informed care translate into practice and into how you evaluate your practice? That's a different story. And we need that in concrete terms. I think one of the biggest lessons in terms of the pandemic has been the role of non-traditional health partners, community health centers, community associations like Jamaica Canadian Association, have been used as platforms for health service delivery and vaccinations. In the States, they've used barbershops, churches, synagogues, mosques, temples to deliver primary health and vaccinations at the same time. And it's worked. It's been better than if they delivered through some hospitals, as a matter of fact. So I think non-traditional health partners that are trusted by community, and community health centers tend to be trusted by community. That's where they go when they have the fever and the flu or the headache or whatever. That won't go away, or the migraine. So they know the people there, and that makes a big difference. So I think boosting those mediums, such as community health centers, as a model is what I would recommend. I think, going forward, it doesn't make sense to me that primary healthcare physicians, family health teams aren't vaccinating people. That don't make no sense. So we need strength to strengthen primary healthcare, but we also need to expand community health centers and the support for community health centers that people trust.
Thank you so much for that answer. I completely agree with you. I think it was important that you highlighted the strategies, such as making sure that we acknowledge the past and present injustices rooted in our policies and healthcare practice delivery, making sure we partner with trusted sources like faith-based organizations, community health centers, and grassroots, and also developing, I think another element we can focus on as another strategy of rebuilding that trust is developing culturally specific messaging, like the one you shared with us in the beginning, and making sure that we're acknowledging the valid concerns of the community, as well as providing important information and education, and then bringing these services directly to them. And then my last question, it does tie into the previous question. So if you would like to add to it, or if you feel like you already kind of touched on it, that's okay. It is, how do we combat vaccine hesitancy? So it's a continuation of the previous.
Yeah. So it's a marathon. It's not a sprint. It took us centuries to get where we are, and it's not going to take us centuries to get out. Thank goodness, because I think that time is speeding up. Hey, nobody, I'm speaking, you have to be serious. My solution to life: laugh, smile. It takes you places, it reduces the stress. Smile more, laugh more, have more fun. Yeah, so moving forward, I think we need to have a greater focus on harm reduction as part of a continuum of care. I think we have a lot of problems that's not getting dealt with because we have a sort of a stigma and blindness on the problems themselves, and cannabis addiction, opioid addiction, alcohol addiction, cat addiction. I mean, there's a lot of addictions out there that aren't being addressed, and part of it is the reason that there's no harm reduction, so it's either abstinence or nothing. And that doesn't work because some people don't want to stop using, they don't want to stop drinking, they don't want to stop smoking, they don't want to stop taking drugs. So how do you make sure that they take it safely? And Black cultures, especially traditional Black cultures, tend to be abstinence cultures. So we need to make some cultural shifts. But it has to come out of conversation and discussion and dialogue with our elders, with our scientists, with our people across the spectrum, and say, it's no longer realistic to hold on to this view because people get sicker and die, and we don't want that because they have cultural creativity, they have science, got bright people wasting their lives and having excessive death rate. So I want to see more harm reduction. One of the other things that we learned during the pandemic is robust case management systems work. We always knew it worked, but the determination to help people with addiction problems wasn't always there, or mental health problems. Housing first. To expect people who have addiction and housing to solve their addiction problems while they don't have a house or a home or a job, it doesn't work, So they need robust, as a Trinity, I'm saying it in a Trinity, robust case management. And we also need to amplify our cultural culturally responsive approaches and treatments. You got to be able to step out the door and get it, whatever it is you need. And I'm not thinking about technologically, you know, what they call it again? They say they're developing care for the individual. It's all about like a technological advance. I'm talking about you get out there and the van with the medical equipment is in front of your house or in front of your building. So there's no access issues, no vaccine issues. You don't have to take off work to get a vaccine. It's out here, it's right there. You get out. So you have no reason for not getting it. And at the same time, when you get in that van, they talk to you in a way that you understand. It's English, but it's also idioms that you understand. So when you say my belly hurting me, you know, I ain't nothing wrong with me. This is belly. I just had a belly pain, it won't go away. They know you got depression. You ain't talking about no belly. You're somatizing. You know, they know because they did their homework and they know. You need those grounded cultural approaches, cultural competent approaches, so people know where you're coming from and they could diagnose your conditions properly and treat you properly and interact with you properly. And, you know, because trust is medicine. Trust is medicine. If you don't have trust, that person is making you sicker. So that's like anti-medicine. So trust is like medication, which to me, you know, I tell my dad, food is medicine, water is medicine, because you don't like to eat and drink. But you know, this comes out. So that's my learning tonight. Trust is medicine. I'm gonna start saying that from tonight. Trust. Hey, I know that in relationships, trust is essential. Now I know in healthcare, trust is medicine. Because if you ain't getting that, you're getting sicker. Your conditions are worsening because you're leaving that interaction with more stress. You know, you got more cortisol running around your body and aging you and weakening your immune system to the disease or what have you. And you know, my cousin had cancer, breast cancer. She defeated breast cancer because she changed her diet, radical diet. And she also stopped watching any serious TV shows, only comedy. She was determined every day. All she would do is laugh her way through whatever life she had left. And believe you me, that was like about 15, 20 years ago. She was a young woman when she was diagnosed with breast cancer, and she's still around. She got, you know, living life, you know, so trust and laughter is good medicine.
Thank you so much, Dr. Khenti. So now I will transition to Theresa, and she will provide our next question. Thank you.
Thank you, Meron. We're actually a bit short on time, so we will now transition into our question and answer period. So I'm going to open the floor to our audience. So if you could please raise your hand, or if you prefer to pose your question in the chat, we would really appreciate that. We also have some additional questions that we received in advance of today's discussion, just in case the audience needed some time.
It looks like we have a question, Theresa.
Okay.
Hi, everyone. Nice to see you. Good evening. My name is Dan Harris. I'm here with David. And it's a pleasure to be here tonight and hear you, Dr. Khenti. Thank you for spending your time. And thank you to the whole panel for preparing a very nice series of questions and getting us going. So my question for you is, what do you think can be done on a structural and policy level within Canada and within Ontario, perhaps, to address issues of anti-Black racism, in particular to kind of advance Black mental health?
Two things. We absolutely need race-based data for equity purposes. We need race-based data collected right across the system so that we understand the disparities where they exist. And the other thing about that is that it must only be collected for equity purposes, which means that whoever collects it has a responsibility to do something with it. So if they identify a disparity as an institution, they have to act on the disparity. They can't collect the data so that researchers could access the data. Then absolutely, we need to be able to access the data, but they also need to use the data if they find a disparity, because otherwise don't collect the data. And we need that data, because what we've seen is that we think there's no problem when you collect data, huge problems. So that's number one. I want a universal basic income for all, not just for Black people, for everybody, because I believe in targeted universalism. But I also believe that that inequity in income drives so many health disparities that if you addressed it, you may actually have, you would have a significant effect on some of the, you'd mitigate some of the risk just by doing that. And especially for people who are in these occupations like healthcare work, PSWs, right, who earn below the low income cutoff. So they have to do 2-3 jobs exposed to increased risk. And it's a job you can't work from home, and you're in it, And they're continuing, they're doing it, but they could do it better, and they could do it in a way that doesn't involve so much stress on them and their families, which actually affects your immune system and makes you, if you get COVID, you're gonna get sick of severe COVID and all that kind of stuff. So those are my two things: race-based data, a universal basic income, so that we don't have people working 2 and 3 jobs and still below the poverty line or below $40,000 a year. And that $40,000 a year is like a cutoff. People who earn less than $40,000 a year have a different COVID experience than people who earn more than $40,000 a year. That's been the pandemic learning, right? So I think the income is a big thing. And race-based data in real time. So we haven't been able to collect it in real time. We collect it. And then if a jurisdiction wants to do something about it, like Toronto, we find out. But Thunder Bay, who knows what the hell is going on in Thunder Bay? They're supposed to be collecting it, but nobody's checking, so nobody knows. But I'm sure that there are disparities up there, but it's indigenous disparities. We need to know now so we can act on it now.
That's great. Thanks so much for that answer.
No problem. And just as a closing, race-based data collection by itself doesn't solve any problems. The US collects tons of race-based data, and sometimes nothing changes. So that's why I say you got to use the data that you collect for health equity purposes.
Thank you, Dr. Khenti, for answering that question. We also see another question in the chat from Pablo. It says, what role do you see for K-12 education?
K-12 education?
Yes. And thank you for your question.
Well, K-12, it's the most vulnerable period of childhood. And the problem is parents, many parents of Black children, that's Black parents and non-Black parents, because you have many non-Black parents of Black children, aren't equipped. They don't understand anti-Black racism, so they can't prepare their children in their verbal years. It's another story in your non-verbal years, daycare, kindergarten, grade 1, but even in your verbal years, so that when you're not affirmed, when you have a problem, you can't articulate it, or you don't deal with it in a positive way. You deal with it from a place of anger, not from a place of, that has nothing to do with me, because I'm here to be a genius. I'm here to change the world. So if they ain't letting me answer questions. In Waterloo, they call the police on a 4-year-old. It's an incredible story. And I know people in Waterloo trying to get letters written to the education minister asking for an intervention in Waterloo, because it's outrageous. So why should, these events tell you that there's a lot more going on, and you can't let children on their own devices. They have to be protected. The question is, how do you protect them from anti-Black racism? And that anti-Black racism expresses itself in 3 ways. failure to discern their intelligence, failure to see the responsibility that you have as the educator to bring it out, because you're assuming there's none. Failure to appreciate Black beauty, because you're holding them to a standard and you can't, oh my God, what a beautiful child, because that child doesn't fit your standard or your paradigm of beauty. And all these things have to be built into the understanding that educators have and the responsibilities that they have to overcome it. So stigmatizing assumptions, we all have it because we're living in the culture. So we all have it. Black people have it too, by the way. So Black people looking at the dark-skinned child, the fair-skinned child, and seeing more potential in the fair-skinned child. Black people do that too. Black parents and Black families do that too. The question is, how do you educate educators so that they don't do it? They don't fuel that disparity in the children that you ask. You ask me this question, which becomes a mental health problem, but it's not a DSM form type typical mental health problem, but it's a typical Black mental health problem because you are not validated in your beauty, affirmed into your intellect, because people think you're dumb or you're less intellectually equipped than others. And it's a real problem. So I say, this is where anti-racism has to be very strong and very strident, and the expectations have to be very high.
Thank you.
Did I answer that question adequately?
Yes, you did. You did. We're just being mindful of time. We do have 4 minutes, but I saw there is one question in the chat. If you could quickly answer it before passing it on to Kelty and Rebecca. But Angela here is asking, thank you, Dr. Khenti, the panel for a great discussion. Could you please expand on trauma-informed care and how we can translate it into health systems?
Yeah, so trauma-informed care teaches you how to recognize patterns of behavior that appear to be violent or confrontational or threatening or problematic, but actually can be well managed, can be de-escalated, can be controlled. It's not behavior that you need to call the police for. You can actually talk the person down or explain it to them or work through it with them, right? And you have to note the interventions that work to do it. Like there's a Sudanese guy was killed in Calgary two weekends ago, 2 Sundays ago. And not only was the policing crazy, they killed him because he was actually, he was hitting a dog. He was hitting a dog with a stick, a police dog with a stick. But the guy was actually in a psychotic episode. And there was no de-escalation, there's no engagement, no talking down. No, they didn't think of the uniform, for someone who has been a war, he was a soldier, a child soldier, and all those kind of. So there's triggers, and uniform is a trigger, and trauma-informed care knows that if someone has that background, and I think that they have a case file. Because usually when they call when these guys are repeat offenders, like 4 calls in, live in a certain building, the police constantly go to there. They actually know the guy. They know what the issues are. They know what his triggers are because it's in the file, and yet still they're not providing the care or the intervention that matches the need. So trauma-informed care is about having or developing an intervention to match a need, grounded in a particular experience that may only be yours, only be his or hers, because they have a background of slavery or colonization or what have you that has expressed itself in a particular way. And you need to know what that way is so that you dress accordingly and act accordingly and interact accordingly with the individual. And that hasn't happened with him. It didn't happen with Loku. This was 3 Sundays ago in Calgary. We had the situation in Ottawa. That was last year. And we had Loku 3 or 4 years ago in Toronto. And people in mental health crisis, and there's many other names I could call. Same situation, fatal outcomes. But those events are just the events which illustrate deeper patterns where you don't have a fatal outcome, but maybe you have fatal morbidities or negative morbidities that occur because of the lack of the appropriate responses. You know, so the fatal outcome is just the worst outcome you could get. But I'm thinking that there's other terrible outcomes, but just not as bad as a fatal outcome because of the lack of trauma-informed care. So that with many women, it's rape or sexual abuse. Women who have substance abuse problems or dependency, usually there's a greater likelihood that that's a factor. But how you deal with that, how you counsel with that, you got to create certain environments. You got to make sure there's people safe to have that discussion, to bring it up. Definitely can't bring it up in a mixed group, so that you become aware that if this person is more likely to have this background, then you need to ensure that the group that they're in fits. You understand? Otherwise, you may re-traumatize them because it may become a point of humor or jokes or what have you, or whatever. I hope that answers the question. It's a tough question, but I hope that answers the question.
No, thank you for that, Dr. Khenti. I think you answered the question really well, and I think it's important meeting patients where they're at. Again, we're done, so I will pass it on to Kelty and Rebecca. Thank you again, everyone, for joining us and having us as your panelists and moderators. Yeah, I'll pass it on.
Amazing. Thank you so much, Dr. Khenti and Theresa, Tionné, Bemnet, and Meron. We really appreciate the time that you took out of your day to be a part of this. We'll keep it short. Becca and I just wanted to do a gift card giveaway all of February for Black History Month. We've been giving away gift cards to local Black-owned businesses. So Rebecca will post those names in the chat, and then we will follow up and make sure that you get your gift card. Anything else to add, Becca?
No, just a huge round of applause for all of our speakers. This was such an amazing chat. I learned so very much, and I really appreciate you taking the time to share all of your knowledge and your experiences with us.
And we will pass it back to Theresa just very briefly. Thank you so much.
Yeah, just a few closing remarks here. We want to thank you, Dr. Khenti, for your time and for enlightening us with such an insightful and important discussion. And also thank you to everyone for joining us this evening. It's been a pleasure, and we're very happy to be able to have concluded Black History Month and Black Futures Month in this way. Our hope is that these discussions don't dissipate as we move into March or as we move towards reopening. And these issues will continue to require attention and our actions. And so we encourage everybody to critically think about them as we navigate through these spaces. So I'm going to hand it back to you, Kelty, for the giveaway. So thank you.
Thank you. That was the perfect summary. We just posted the names in the chat. So it's Lydia and Noreen. Feel free to email us. We also have your contact info from this event so we can follow up. And yeah, I really just appreciate the moderators and Dr. Khenti taking their time this evening. And we look forward to continuing this discussion, as Theresa mentioned, not just during Black History Month, but throughout the entire year, and making sure that this is heard at Dalalana loudly for the rest of our time here.
Enough respect.
Thank you, Dr. Khenti.
Thank you so much, everyone.
All right.
Thanks so much, everyone.
All right, take care.
Will
Stay
do.
safe.